Okay.
在下边播放一下。
Okay, it's a case report about anterior hunting surgery. This is a 64 years old female. It's a rheumatoid AAD. So it's with a osteopenia. Others, no special information. I would like to skip it. This is MRI. Okay, you can see the dislocation. This is a dynamic DR. You can see the unstable on C1 and C2. And you can see the CT scan from sagittal, transverse, or the cranial section. You can see the osteophytes formation at the C1 and C2 facet joint. And especially you can see at the tip of the scan dens, there is also some osteophyte formation. So we choose, this is the first patient we do anterior hunting surgery. So we do some calculation about, it's a CAA about 140, OCC2 is 4 degrees, cervical lordosis about 28 degrees, and T1 slope 25, and SV 2 centimeters. This is we focus the facet joint, the inclination. So it's about 144. It's not very large, not steep one. So we do from the anterior transoral approach. We release facet joint anteriorly and put in a cage. You can see an intraoperation expert film. And then we use a plant. It's Atlantis. This is a post-operation MRI check. It's okay. You can see the totally decompression of the medulla cord from anterior. The CAA is good, and cervical lordosis is realignment. X-ray, DR. So 6 months later, in the follow-up, we find this patient has a little cage subsidence. But okay, we just a little worried about the bone fusion. This is at that time MRI checkup. It's you can also find it's a little subsidence of the cage. 6 months later. So finally, 1 year, we get the fusion of the C1 and C2 facet joint at the last. Thank God. So this incision of this operation, you can see after 7 days, we can see the infection of this incision site. 2 weeks later, it's much better. 1 month, okay. So the progress on CCG in the last 20 years may be two parts. One is cervical alignment evaluation. The second one is surgical techniques. No matter spacer or the C1, C2 or anterior surgery. So I would like to discuss two questions. One is saying reduction is important, but how to balance the C227 lordosis with T1 slope during reduction? Because we find some patients, especially with a small Cliver slope, sometimes you do lots of energy to reduce the CAA, but you got cervical kyphosis after surgery. The second one is anterior only surgery is indicated in AAD patient with high SJI, especially when it's over 160 degrees. So we all know it's a lot of this kind of mathematics. It's quite. So I like to say this one is very important. In Dr. Zan's presentation, you use a T1 slope minus 15 equal to a cervical lordosis post-surgery. Or I like to use OCC2 equal to 3 times of C1 cervical lordosis. So do we need to balance the CAA and T1 slope? And or we need just to focus on reduction in AAD patients? So this one you can see. CAA angle from 110 pre-operation to 127 after operation. At this time after operation, OCC2 from minus 20 to 0 after operation. And T1 slope is 17. It's ideal. One is 2 to 5 degrees. So it's a description between the cervical lordosis. What I mean is you reduce the CAA, you get cervical lordosis. But this the cervical lordosis at this time is suitable for the T1 slope, or what kind of degrees you should do for the CAA reduction? Okay, this is maybe I think this picture we can see the reasonable region you should put in during operation. COO2, you should, we think you should put in the 10 degrees to 25 degrees. This region is okay. So this one is located in the triangle. This is a reasonable region. This one is, it's, you can see, sometimes you can see this kind of reduction from 110 to 140 after operation. But this one, CAA is good, but the lower cervical lordosis is something kyphosis. So this one is located here. This one is good. It's recovered to normal size of the CAA, and we get a reasonable cervical lordosis. But this one is it's questionable. If you use destruction techniques, the after operation, the cervical lordosis and the CAA is in here, it's quite different. So we think it's 15 to 30 is okay, but it's good is 20 to 25 for OCC2 during operation. If you get 20, it's okay. The cervical lordosis is good. So the question 2 is anterior operation anterior awning surgery is suitable for high SJI patients. Just now, I hear from Dr. I's presentation. He answered my question. Yes, anterior approach used in the reducible dislocation or in reducible dislocation with SJI less than 160. You can see transoral, transoral, transoral. But larger than 160, it's a question. So we focus C1 and 2 joint. In this one, larger than 160, it's a most challenge for the neurosurgeon who do the craniocervical joint malformation. So posterior awning surgery, we use a cage Spencer here. We do this. Some patients okay, but this one published in paper, some cases it's not very good in reeducation. So you can see insufficient reduction in this one with SJI 178 degrees. They use a technique called EAD, but we question EAD techniques. It's have a lot of problem. We will talk later. Reducible dislocation or irreducible dislocation. If the inclination less than 160, anterior or posterior release both be okay. So we know from the Dr. I from Guangzhou Hospital, there are lots of experience of that. We just we get a picture from their papers published in journals. Their cases is SGI is about 120. So I just wonder it's effective in high degree of the facet joint, slip facet joint. It's this paper from India. They do the same, put a cage in the facet joint anteriorly, but the SJI is only 90 degrees. Why just want to, it's effective in a high degree of facet joint. So I just questions, in cases with a high SJI, larger than 160s, is effective. So we know if you put a cage in the true joint, it's quite difficult from anterior this way. So in the last, I comment for the reducible anterior only or posterior only, both be okay. In reducible with SJI less than 160, anterior, posterior, or anterior, posterior, both will be okay. But in reducible dislocation with SGI larger than 160, anterior only question is need further verification. And posterior only, some patient okay, but some cases not very good. EAD we question a lot. Anterior and posterior, the classic one is very good. Okay, thank you for your attention.
Maybe Professor I will comment on this topic of Professor Feng. Are you still online, Dr. Edward 在吗？
Okay. I think from the anterior transoral approach is very important is technique supplementary for the posterior approach. But as Dr. Feng said, the angle which is more than 160 degree is not suitable for the anterior approach. But in my opinion, from my experience, if the surgery cannot suitable for the posterior approach, I can perform the transoral approach to perform this operation. All the cases I can perform from transoral approach, but not all the operation can be performed from the posterior approach. So I think the transoral, even for the technique, transoral can perform every operation, but posterior cannot do all the operation, in my opinion. But because the infection rate, many surgeons may say that the infection rate will relatively high and the posterior approach. So we still use the most cases by the posterior approach because they are reducible. Even after the heavyweight traction during the operation, it can be reduced. So we perform this kind of patient by the posterior approach. So during the upper cervical spine patients, most patients can be performed the operation from the posterior approach. But in fact, all the patients can perform the thorough reduction from the transoral approach. In my opinion, I have performed every patient from an anterior approach. It will be called okay. The result is factory.
Okay.
Satisfactory.
Okay, thank you.
May I have a question for Dr. I? Okay. So now you said in your transoral can do all the cases of the dislocation cases. So you see some of the cases I showed in my cases, they have the basilar imagination, but they do not have a dislocation of the C1 and the C2. So do you think this time you have the TARP may works or not? Or
okay, I see. I know your meaning. In this kind of patients without dislocation of C1-2, it has the ventral cord compression is always not severe, but the patient have the syndrome. In this kind of patients, I have tried the TARP procedure to decompress the ventral compression. After that, because it's unstable, so we use the TARP for the internal fixation. All this is not too much, not too much, only about no more than 10 cases. This kind of Atlantic actual it is stable patients. But even I performed the TARP operation, they most of the patients have recovered. They get their syndrome relieved, but a little patient cannot get the satisfaction effect. So this kind of patient I introduced to the posterior approach.
okay. Okay, I see.
Okay, Dr. I just you give us a very impressive presentation. You answer my question. I just wonder if the facet joint have a high degree of inclination, like 160. I used to think it's not possible to do it from the anterior. But in your case, answer my question, it's okay. Right. The second one, I think it's, I like to suggest, I see you, the instrument, reduction instrument. I'm curious about that for many, many years. I see
I will show you.
I see your picture, yes, but I don't know the mechanism. So for me, this is first time I see the mechanism, the instrument. It's good. That's impressive. I just a little suggestion. I see you do the bone fusion between the anterior tubercle of the C1 and the dens, right?
Triple joints fusion. During the
you do the fusion in the facet joint, right?
Sure.
Oh, okay.
Only I always
can put a cage in that one. It's like a lumbar surgery. Because I just understand you do the fusion just between the tubercle and the dens. It's like the posterior lateral fusion in the lumbar surgery.
No, that is not true. That's not true. From the first case, we used the autogenous iliac bone graft into the lateral joints.
The bilateral facet joint.
Yes, right. From the first case on. But after several years, we placed the bone graft, not the granulate. It's the how to say 楔形怎么说 shape how to say
why do you put some cage in the facet joint?
Because we always before we always think the fusion rate is very important. So because some redislocation happened again because of the non-union of the Atlantic axial joints. So we are afraid of union. So we always use the iliac bone graft.
I mean, if you put a cage in the facet joint, you do not need pedicle screws. Maybe
I will try it. You have given me
some vertebral screws may become stable.
I think it's a good idea. I have we have
maybe you can design some small cage or material.
Right.
In the facet joint.
We have designed it, but not used in the clinic.
Okay, thank you. Weixin, any question? Okay. Professor Dimleli, do you have any comment?
Yeah, actually, it was a very informative webinar, really. I haven't seen before the TARC application, the technique of TARC. It's very informative. I enjoyed all the speakers. Thank you for giving the opportunity to get together all these nice speakers.
Okay. 罗元涛有什么问题？
Actually, I have a question for Professor Chen. In clinical, we find some patients have some you said CXA angle is small, and the patients have basilar invagination, but the patients didn't have atlanto axis dislocation, but the patients have the calcium malformation, but it's not type 2, it's just type 0 or type 1, and have shringomania. Do you think we change the CXA angle will be helpful to release the shringomania or calcium malformation? Professor Chen?
Disappear.
There's some wrong with the network.
Okay, some problem of connection, maybe my problem. Okay, I think we have a clinical program.
Like the Professor Feng, the third case. do you think that if we change the CXA angle will be helpful?
Sorry, I think we have some problem of connection.
听不到吗？
不，其实录音刀，我告诉你，你提的这个问题啊，它不是解决那个角度的问题，你那斜坡还在上面，你随便怎么做，你再把它加大，你也加不到那个接近正常都不行。
那你觉得
那种病人
就需要去磨除那个？
对，那不是解决那个，它就相当于就是老简说的那个叫斜坡
AT 和那个 CT 的问题是吧
？AT 就是斜坡那个 tute。
I think we can discuss this question later, not online here because we have many friends.
That's
right. Friends. So I think it's very late. We have already finished our program. I'd like to thank you all our faculties, and I'd like to thank all the participants online. I think this is really very good way to communicate online, especially in this special period. I totally agree with you, with Professor Gileli. Thank you all. Have a good night. Okay, thank you. Bye bye.
好，谢谢大家。
Goodbye.
Bye
Bye.
Bye.
Bye, Professor.
谢谢各位主任，谢谢。
Bye. I wait for the recordings. Thank you.
Finally, I'd like to thank Chen for supporting of this online meeting. Thank you.
Good. Thank you.
Thank you. Bye bye.
Thank you.